Hi,
Hi
Keela.
there. How are you?
Doing pretty well. How are you?
Also doing pretty well.
Awesome.
I have been playing Tetris with these workflows, so it's always like a fun game.
Fun.
Yes. Oh my
Tetris is a
goodness.
pretty good word
I have
too.
I have a spider that just came to visit me. Let's put you
Wriggled and
over there.
jiggled and jiggled inside her.
It's just came floating down right in front of my monitor. Great. Hope they don't start raining down on me. How's it going, Jim?
Good. How you doing?
Good. I was in a meeting yesterday, the day before, your name came up. I was like, huh.
I got those charges cleared up. It's not my fault.
Uh, no, I think it was Civitas related.
Oh, probably Civitas related. Yeah.
Yeah, because
Yeah.
proposals are due tomorrow.
Yeah. I'm on the fence. We have some topic areas, but they're not well enough. They're intended to be developed more to be able to have substance to then present. So I'm concerned about submitting something that everybody says, "Ooh, that sounds great," and not having the use case develop. So
All right. We are just going to give people another minute. We'll see who else joins us. I'm just getting our notes ready. Ken, if you're looking, I'm just saving today's flavor
Awesome.
template. All righty. So, finally, I got these. Luckily, our meetings are recorded and I could just watch the last time we created the workflows and remake all of the things that I lost in my not saved version. So it's very convenient and I've cleaned them up quite a bit as well. So we can talk about whether or not we can sort of walk through them again. I got most of them edited, so we'll get through the ones that I have worked on and see if A, they're accurate, and B, if they present what we're hoping that they present around the workflow for using credentials in sort of the medical office settings, and those interactions, or whether we want to change their presentation so that they communicate our message a little more clearly. So I think that's kind of agenda. But I've jumped ahead because we have to do our housekeeping, which is that we are at the fourth Thursday of May. And we are at the Cardea working group, a member of the Hyperledger lab community, and therefore we are governed by the Hyperledger antitrust policy, as well as the code of conduct, which say that we're not going to talk about explicit business cases here and monetary aspects, and also that everybody's encouraged to have a voice. So I think everybody so far, we know each other and we can skip introductions. Um, but just keep that in mind as we navigate through today's discussion. Okay, so with that said, I can now pop over to the workflows. So let me share my screen and let's dive in. You're on my big monitor, so just let me know if this is too small for you and I can change my display.
That
Is that good?
monitor's huge. Can you zoom in just a little bit?
Here, I'll just change what I did. Hold on. I will switch to, yeah, it's big enough that I have to like turn my head, that's maybe too big. I'll just change the ratio. Is that better?
That's much better. Thank you.
Wonderful. Okay. And I want to stay in edit mode, so not presenter mode, because we're going to make some edits as we go here. Okay, so just to kind of get everybody back to where we were talking about a credential, a verifiable credential for the purposes of doing patient identity in relation to a clinical practice. And so to help facilitate those conversations, we really need to have the workflow that describes how a verifiable credential could be valuable in these workspaces and interactions. And so that's sort of what we've drafted here. We've gone through a couple of scenarios like a new patient creation, and we'll talk through like scheduling an appointment and showing up for a visit and things like that. So that's the context of these. We've reviewed them once before. They were a little rough around the edges, and so hopefully these are in a little better shape for the purposes of today's conversation. So what probably makes sense is for just to walk through this, and let's make sure we think it's accurate, and then we can go from there. So a new patient creation, I've split this up so that this swim lane is the practice, and we have a patient swim lane where they interact. So the system, they may have gotten an appointment request online or something like that as an existing patient. If the answer is it is not an existing patient, then the staff is going to collect patient information. They're going to create an appointment. Usually you don't just call to say, I want to be a patient of your practice, but you want to be seen. So they would collect like the minimum to create the patient record. They would book that appointment. And then there's the question about whether or not the practice uses digital data collection or not. So this is like paper forms or, do they hand you an iPad kind of thing? And so if they don't use digital, so we're going to paper, they would give the forms to the patient. And I guess I'll come back with my thoughts in a minute. So they would give the forms to the patient. The patient would fill out the paper forms with their personal health information and PII. They would pass those forms back to the front desk. The front desk would enter, beef up their electronic record for that patient. They would take a photo so that we have the identity binding to that medical chart. And then there's a sort of a question about whether or not we have already exchanged a credential. The answer is no. Then the practice would present a QR code to the patient for them to establish the secure connection. We could probably draw a little loop over here that the patient does that. And then the system would create a complete credential. And that would be the end of this flow. If they used digital information gathering like an iPad, then the practice would hand the interesting. The patient presents the credentials to the web UI to pull up check-in forms. Got it, because it could link it directly to the chart. Because
where did they get the credential?
that is a great question. That is a great question. We had originally, and I deleted our old version, we did have that we had some question about whether or not they created like a bare bones credential at the beginning, but I think you're right that this is wrong. I think what we would do, I think the point is that if we're doing digital data collection, then it should go directly to the chart. So it should already be linked.
Instead of presenting a credential, this just needs to be scans a QR code to establish a connection and bring up the chart.
Okay.
And it'll be an empty chart because they haven't presented anything. It'll just be, data entry here. And that's actually the next step is they're entering the data. So
oh, thanks. Jim, you came off. You turned on your camera. Do you want to chime in?
Yeah, I haven't. It's okay. I think I'm still in listen mode. I have a couple questions, but I'll just continue to follow the flow here.
Okay. So the patient is going to scan the QR code that would link them to their chart for them to finish their sort of patient registration, initial registration. So they would do that. And then it would go back to the front desk where they say, I'm done. Okay, we still have to do the picture and the identity binding. So that would still happen. And in this case, there was a credential exchanged already. And so they would be able to issue the credential directly to them because the scanning of the QR code happened here.
So
for that flow.
I would update this one to say,
this one.
Yeah, that middle box, because the this is a new
Is
patient
there
flow,
a
and
secure connection?
right, because this is the new patient flow, and they don't have a credential yet.
Is that a secure connection to the patient or
Yes.
internally for, okay.
Yes. Because wouldn't this scanning of the QR code create a connection, or that's just shortcutting them to their chart?
You could do it a couple different ways. One thing you could do here is have the system could direct them to a web page that provides them with the single use or individual invitation on the page before displaying the chart. And then at that point, you would know that the data from the chart fields would be associated with that connection. The other way you could do it is you could have them simply bring up the web page and enter the information, and then do the connection with an individual invitation later. It's probably one or the other.
It's probably this one. Let's do that. Because they're going to hand them an iPad. They're probably not going to have them do it. Maybe they do it on their phone, but probably they're handing them an iPad. Kind of
Somewhere in
thing.
the process, they need to download a wallet so that they have an application. So I think that's a step that should go somewhere.
Yeah.
Yeah, I guess, yeah, at this point, I'll kind of step in. This is stuff that we're kind of kicking around at MyLego, which is certainly for a significant number of use cases, they're going to have to be custodial wallets. If you're looking at it from a health equity standpoint, I cannot ask a 75-year-old Medicare recipient to fill out something on an iPad and then say, go to this website to download your wallet. You're like, well, I got my wallet right here. So to the extent that it can be automated and then presented to the patient, here you go, just take this or click this link that I texted to you, and not require a lot of web-based interventions, then you'll limit ruling out a population that just says, I'm not going to do that, or I can't.
Yes, I agree with all of these sentiments. But there are a couple of pathways here. So let's draw one, which is that the patient is capable of downloading the app and scanning the QR code to get their credential. So that's one option. Because I totally agree with you on the equity side of
Right.
it, that people just cannot. We're asking.
Yeah. And we can
you know,
keep it all in, you can keep it all in one workflow diagram, or you could have subset diagrams that is, workflow for the Gen Xer or the millennial that walks in and can put the whole thing on their phone, a workflow for somebody with socioeconomic challenges that has
a burner phone or a flip phone.
a flip
Yeah.
phone, or they pay for Cricket Wireless or something like that and don't have access to a laptop. And then older populations that really aren't going to be technically savvy enough to ever use this properly.
Yeah, so what we can do is, maybe because it's going to mess up our diagram quite a bit, we're going to say this assumes a digital wallet. Because I think the other reality is they need to print their QR code for somebody, right? They need to print something, because I don't think how do you address that, right? Even emailing it to them isn't necessarily productive.
No.
So this flow will just sort of assume that there's a digital wallet involved, and then we should talk about that.
Let's call it a mobile digital wallet.
Yeah.
Great. And that way we've highlighted that we need to come back to elaborate on those other flows. So here I've added assuming that this digital wallet flow isn't in effect, though, I did add they have to download the app, or patient has wallet or downloads. Right? I can make that better later too, because that's a question. Do they already have one or not?
Yeah, because this also gets into things like at some point, if a payer provides you with your wallet for your benefits, and you're going from one doctor that's you've been referred from an in-network doctor to another in-network doctor, that other in-network doctor should be able to just scan your QR code and say, "Oh, I know who you are." So
Yes, and that's a separate workflow. Agreed. Okay, so then they would, because we presented the QR code, they would scan the QR code and they then we do have the connection, and so the credential would be issued. I also think this, oh, sorry, the beginning of this workflow makes me confused. So we already said it's new patient. I'm going to get rid of this whole thing over here because that's confusing. It's really that patient presents for their first appointment at the wherever they are. I think what we were trying to highlight, but then we didn't get into the mechanics of it, is that sometimes they send you like fill out these forms before
right.
you show up at the doctor's office. We started, that was sort of the idea behind that flow, but then we didn't elaborate on it fully. So I think we should expand this, but maybe this is the like easy flavor at the moment. So this is, they show up and it's a new appointment, and we can add because they might do this part, they might do this at home. And I guess this workflow kind of neutralizes that, because it could be that they emailed this in advance, right? And then they show up and they say, oh, okay, great, you are who you are. And they kind of enter the flow sort of through this pipeline rather than through the form pipeline. So I can
you could put
monkey with that.
underneath the yes flow, does the practice use data collection to say web-based or iPad or mobile phone based? You can have any of those methods, right?
Yeah, electronic versus paper-based.
Yes, you're wanting me to clarify that this is iPad web-based.
Or app-based. So like if they have an app from their insurance provider, it could be in there or whatever.
Yep. And I think that the other point was that this patient presents for first appointment, they could have done that in advance. So it's really that I'm trying to spare all of you my manipulations here, but we'll do it a little bit here. Really the first question is, no, it's the second question. The next question after this is, do they send it in advance?
Yeah.
And that would just indicate like kind of where the patient, because, oh, sorry, because if the answer is no, then the patient is presenting and they're handing them the paperwork for the first time. Oh, sorry for my editing, everybody, bear with me. I was trying to bypass some of this. Okay, they'd present and they'd hand them the forms, right? And the case of they did send them in advance, then the patient would present here. I'll have to fix this later. And in the case where they didn't, the patient would present and then they would be handed, then they would do the data entry. Right? So there's 3 points in which the patient actually shows up at the office.
Yeah. So intake form in advance of appointments, yes or no. Option 1 is intake form in advance of appointment that's digital. In other words, they capture information in a Perl script or something like that that populates things in the back end, or as I've encountered, which is intake form before the appointments, and it's all PDFs. So there still has to be manual manipulation of the data. And then second option B being you don't fill out anything until you get to the office. Maybe you'll fill it out electronically on an iPad. Maybe you'll write it out on a piece of paper.
Yes. Okay. So does the practice you, so sorry, I was editing while you were chatting. We're saying, no, that's quite all right. We are saying that the first question is, do they do digital data collection? The next question is, do they do it in advance? Yes, great. They're going to send it to the patient and they're going to fill it out. Then the patient shows up. Then they do the identity binding and they exchange the QR and create the credential. Does the patient do digital collection? Yes, but they don't do it in advance. They do it when the patient presents. So they present, they hand them the iPad or whatever. They got it. Then they can't present here. Okay. Let me break this guy. I'm just gonna still goes here. Okay. I have to figure out how to fix that because that is not right. But shoot. Okay. We'll fix that later. Somewhere along the lines. This is over here. If they filled out this out at home. And then if they don't do digital data collection, then they would present for the first appointment. They'd be handed the paperwork. They'd fill it out. The staff would have to enter it, do the identity binding, etc. Now you were clarifying, Jim, you think that there's another path, which is they send them in advance, but they're not digitized.
Right. It's still a manual data collection effort, either in advance of the appointment or at the time.
Which would go, where do we want to put that? To me, I would say that that kind of doesn't count as digital data collection because they're going to hand the paperwork to the front desk. The front desk needs to add it.
They'll either email it back or hand it to the front desk. It's just really the difference of in the credential generation process is the information readily available in a digital form to kick it off, or else they have to manually enter it into the chart.
I think that step for manual entry is accounted for.
Okay.
So there's the box in the top right corner that says patient fills out the forms, and these could be paper or the iPad that's there in the office, either one. And then the front desk, it says front desk enters information into patient chart in the next arrow. And so whether that's they take the paper forms and the front desk enters the information, or they've got it on the iPad and they just confirm that it's in the system now, one of those two things means that it's now digital and reviewed by the front desk.
Interesting. Okay, so you're suggesting that this front desk, quote unquote, enters information or verifies the information should always be where it goes? Mike?
That's the flow for everyone who didn't fill it out in advance. So they show up, your top path is the practice.
So you're saying no, they don't, they go there. That makes this way easier because I was stuck in a loop. Okay.
Yeah, I think that's a good way to do it.
Okay, that makes me much happier. So basically it doesn't matter if they're what kind of way they're doing it, it's whether they do it in advance or not.
Yeah.
Okay, excellent. Any other corrections?
It looks a little
comments?
goofy. So they show up for their first appointment, but they send it in advance. And they're still filling out some stuff.
Oh, they're doing this at home. This is at home. Oh, I see what you're saying.
So maybe the presents for first appointment goes after that.
Yeah, yeah.
Yes,
Yep.
that presents for first appointment needs to move. Yeah.
That, I think that
Yep.
makes more sense to me. I got it now. I'm with you.
Okay, nope, that's great. That's excellent correction. Thank you. That is really what we meant to do. So let's fix that. Okay. Okay, so so this isn't, yeah, okay, so do they do digital? No, they present. If they do digital and they don't send in advance, then the patient shows up for their first visit. They give the forms, however they're formatted, to the patient. They fill them out. The front desk enters / confirms, depending on how they did it. Confirms, oh, wait, sorry. Confirms information on patient chart. The front desk takes a photo and do the credential. If they send them in advance, the patient's going to do them in advance. They're going to present for their first appointment, and the front desk is going to take a photo of the patient. Somewhere here, they're also like figuring out who they are. But that's it has identity proof included. So we'll assume, we can just for the moment assume that that's happening.
Yeah, the identity proof included would be whether you came in the front desk having filled out the forms in advance or you're doing it right then and there. In either case, they're going to ask you probably for your driver's license or something to say it is indeed me, and we can associate this photo and this driver's license and this form all together.
Great. Okay, excellent. So then we have that there's probably not a secure connection. They do the QR wallet loop, and then the practice would be able to issue the credential. That's the end of this flow, which I put N just because it's in the middle of a diagram. So it was clear. Any other comments on this one? I think that was good improvements.
That's much better.
I agree. Okay, let's see how we need to edit the next one. So we did specify that there's two different flows. There's an in-person scheduling of an appointment, and then there is we did phone scheduling of an appointment in our last conversation. So just keep in mind we do have two. They're a little bit different. So so if you're going to schedule an appointment, the patient would present their credential, because this is that they have a credential. So the patient would present their credential to the front desk. The front desk would do, like, does the person and their credential match? Is this person the owner of their credential? We've talked about there being a picture as part of the credential. We also have talked about confirming that the wallet has identity binding or digital, biometrics or other things there. So does the credential match to the person? Yes, the front desk gives the patient an appointment, they schedule it, and we have some optional that the front desk sends a message with the appointment details, and or they could even issue an appointment credential, which are both optional. I will highlight this guy so it's clear. That's simple enough, I think. Any comments on that one?
That looks good to me.
Then
What's the alternative action thing?
Oh, if the credential and the person don't match.
Oh. So
How would that happen?
That's the picture. So somebody comes in with a credential and
And it's not their credential.
it's not their credential. So
How
Like
do you
they
handle that?
they accidentally present their kid's credential, or they've
That's very
somehow
generous of
managed
you.
to hack somebody's phone.
Yes. Correct. So we're just sort of not addressing that at the moment because we're going happy path.
Happy.
Yep.
Okay,
Is that
I'm
okay?
okay with that.
Okay. All right. Then we have the remote phone appointment scheduling. So the patient calls the office. Does the patient already have a secure connection? Yes. Then the front desk could remotely request a credential exchange. Again, this is where the binding to their wallet came up. So that's an important comment here. The front, and then they go through the appointment scheduling. Let me just highlight this one too. If they do not have a secure connection with the office, then the office could send an email or an SMS request to establish the connection for the credential. So that is that the patient already has a credential from somewhere else. Because again, they're scheduling an appointment. It's sort of not a new patient because that's the new patient workflow.
So I'm calling them to schedule the appointment and in some way electronically presenting, making a verifiable claim or presentation for my credential to schedule the appointment.
Correct.
Yeah.
Because then they know who you are, right? So this is the idea, Jim, where it's like a health system. So you're calling an office that you personally haven't been to, you don't know them. They don't have necessarily a connection with you, but they're part of maybe a network where they trust the other person's identity credential. And so they're going to say, okay, great, we need to establish a connection. Send me your identity credential and I'll inherit all that data. I'll trust that credential. We're like a network. We've agreed to do that.
Yeah, but if it's a new appointment for a new patient, then you're back on slide 1, which is new
That's
patient
right.
intake. Yeah.
That's right.
Yeah. So this is schedule
not a new patient.
versus schedule new appointment where I've seen my doctor 5 times. I'm going to schedule a new 6th appointment. And in doing so, we've already got an established verifiable claim.
We have a verifiable credential, yes, but
Yeah.
you may not already have a connection with that doctor's office.
I would presume you will if this is an existing patient returning for a new appointment.
So the connection might be broken or missing for a variety of reasons. So if you say, does the patient have a connection? And it doesn't matter why they don't. If they don't, if their previous connection is broken, if it's a new part of the, the same office system, where they trust the patient credential, but it's not connected to their system yet, this part of the system or whatever, it doesn't matter why. If you don't have a connection, then there's a step to establish one. If for whatever reason, like the case where it's your 6th appointment and you do have an existing connection, then you could just reuse it. So, there are a variety of reasons why your connection might not be there, and it's relatively simple to take care of. So I think just saying, if you don't have one, you can get one. So you have a credential and now you get your connection, or you already had a connection and then you end up at the same spot.
Yeah, no, I appreciate that, Mike. And quite frankly, I was semantically interpreting connection to be I'm connected to this office as a patient versus the electronic connection aspect of it.
Oh, yeah.
Yes,
So this
electronic secure connection.
Right.
These diagrams were created initially with a very limited audience, and it had a lot of input from me, which means that I was saying connection from the technical application side of things and not focused on the doctor's office so much.
Right. Now that makes perfect sense. Yeah.
Yep.
Okay. And then I think the last one that I've edited, so we're doing pretty well on time here because there's 2 I didn't get to yet in fixing, but is the checking in for an appointment. So the patient would present at the doctor's office, and instead of shouting their PII at the person behind the counter,
My date of birth is
exactly. They're going to scan the QR code and share their credential with the front desk. And so then the front desk would do an identity verification, a visual identity check. Do they match? Yes. Again, happy path. So no, we'll figure that out later. Yes, the front desk checks the patient in for their appointment. They might. Oh, sorry. This goes here. Okay. Then they might say, do you need to update any of your data? And if the answer is yes, then the patient would provide the corrections. Maybe they got married, maybe they moved, whatever their case may be. They would provide that data. The front desk would revoke the old credential and issue an updated credential to the patient. And then the patient would wait to be seen and be seen separately. And if they didn't have anything to change, they can just keep their credential as it is.
That one's one of the simplest ones so far.
Awesome. Yeah, I'm good with that. Yeah.
This one's pretty clean. Okay. All right, so those are the ones that I got to. I don't know if we want to look at the ones that I have to redo my edits on, or not.
So
But-
part of the tricky on this one and the front desk revokes old credential. What if the
Yes.
credential isn't from their front desk?
Oh,
So you had a case where it was a referring physician from somebody else in the
yes.
another office or whatever.
Yeah, and so they may be presenting their credential to the non-issuer of the credential, basically, is what you're saying.
Correct.
And so then then the question would be, do you want me to create a new credential for you?
Yeah, I would just, it's a very valid question, Ken. I would just hold off on it because there's larger ramifications. Because if the credential is then in turn associated with your records in the EHR, all your record, there has to be some cascading effect for the whole system to say, change my records in Epic to be, Lisa Moore, because I'm no longer Lisa Stansfield. And that would be probably a health information management type process at whatever facility that you're at, and a outcome of that would also be some change to the credential.
Yeah, I think that you could say front desk updates patient chart or whatever, and then you could say issues new credential and optionally revokes old credential, because you gotta deal with that somehow. But you're
Yeah,
at least going to
that's
update the chart, and you're at least going to give them a new credential, and you may be able to revoke the old one.
right. That's a great point, because the workflow for the office to update information is going to be EHR centric. Somewhere there has to be a output or trigger another workflow with regards to revocation and reissuance based on changes to those characteristics. But they're going to go into Epic and make changes.
Or any other EMR system, just to be clear.
Right.
Not just Epic. Okay. So the front desk would update information in electronic health system and issue updated credential. I'm just going to say issue credential new, because it would be new. It's not updated. Issue and issues credential to patient. So then we're saying, does this organization, did this organization issue initial credential? No, we're doing nothing. Yes, we are going to revoke.
Yeah, that accounts for the flow where they can do something about the old one.
And in the case where they don't own it, so they can't revoke it, the update to the EHR, I would assume, could notify the issuing side, perhaps, that they need to do something.
The issuing side. You mean whoever issued the initial
Whoever issued
credential?
the initial credential can do something, but
But would it have to? They might not have any relationship with them.
might not.
So I don't know that that is true.
You don't know what's going to happen on that side, and you can't control it. The EHR could, if they have associated offices, the EHR could notify the associated offices of an update, but the credential may have come from the insurance company. It may have come from another, the parent organization of the health system. So there's a number of cases that I don't know if we can deal with all of them in this simplified flow.
Yeah, and I think that what you're saying is that this no needs to be highlighted, that it's more complicated. right? No, they didn't issue the credential. Maybe we need to do something there, but it's
Yeah,
a complicated thing.
It's beyond the scope of what we're going to talk about today.
Yes. Okay. That's what that's what the orange highlights are. I'll put that key somewhere here so we have it memorialized.
Yep.
So I'll leave that orange and no, because there's other stuff we could do to make this really mature. We're going to skip that for this conversation. Okay. Now let's see how we feel about it. Any other edits on this one? I think instead of going through the ones that I didn't redo, because that's not the most effective use of everybody's time, what I'd like to discuss is and I'll just as a reminder what we had drawn when they get seen, because this is a issue that I've heard about from some of our clinical practices that we work with, which is that there's like a bait and switch that happens in the waiting room. So one person checks in and then they send the other guy in the back. Or oopsies, there's two people with the same name in the waiting room and they pulled the wrong person and nobody realized it until they start examining the wrong body part. So that's a flow that we had drafted, and also the telehealth flow. Again, I didn't get back to editing those, but they're there. So that means we have new patients, we have scheduling the appointment two different ways, we have presenting for the appointment, and then we have that telehealth visit and actually being called back out of the waiting room. Are there any other flows that we want to make sure that we add?
Yeah, I mean, this is all good for like initial onboarding, but then there's also going to be, and I'm not sure what necessarily has, I apologize for missing the previous meetings, what's brought to the evolution for the credentialing, onboarding, and the use of credential. You know, the steps after that are binding the credential with health data resources at one or more facilities, and then consent to share, enabling patient individual right of access, health information exchange, etc.
Yeah, agreed. I think that those are all valid, but because we were hoping that we could, like, this would be valuable from a patient safety and a patient identity perspective on its own. And so it would be an opportunity to sort of get the ball rolling at a health facility or two kind of organization that would get value out of this as it is as a standalone,
So do we
assuming
need
we
to,
get past the digital wallet problem.
I think
Sorry.
we could talk. So another thing we need to do is what if they have a custodial wallet? I think that should be in here definitely.
Okay. Let me just add we need to handle next
That's
steps.
part of one of Jim's initial issues that I think needs so that you're inclusive on who can use the system. Another thing I think we might want to do is start listing some of the things Jim mentioned for uh, advanced features or whatever, and put those in a we recognize that they need to happen, and they're in like phase 2 or something like that, or talk about where some of those other things where they should go.
And I also apologize. I guess I'm trying to also get the gist of understanding how Cardea as the open source platform fits into it. Versus, quite frankly, any other decentralized identity solution.
TBD.
Okay, that's legit. Yeah.
So first get the use case down, and then figure out how can we offer something that fits the or provides the things discussed in the use case.
Yeah, because I'll contribute for the sake of discussion here in an open forum, as well as all of you being friends of mine, that our use case, we're building our POC actually in partnership with HIE. So what we're looking at from a mechanism is that HIEs are oftentimes responsible for harmonization and deduplication of records as they send John Smith's records from point A to point B, and they got 4 John Smiths. As they do that harmonization with whatever mechanisms they have, EMPI or master data management or something like that, they'll then assign a credential to those records and say, hey, hospital B, here's John Smith's information. Oh, by the way, we've also harmonized this or reconciled their identity to 95.7% level of reliability, which is a whole nother discussion on patient matching I won't get into. And here's a credential for John Smith. So when John Smith shows up in the office, here's a custodial wallet, direct them to that. That will be their credential, and they can use that going forward, either for encounters or for shipping data back around. And over time, they'll populate a universe of all the patients within that HIE and offer that credential service back as a value add. Until such time as we ascertain the right market approach to get a health system or a gastroenterology practice or something on board with managing credentials on behalf of the patients for the purposes of patient verification, patient safety, and individual right of access.
Yes, and just for anybody who might be listening to this recording, an HIE is a health information exchange. I think that that is all applicable to what we've drafted here, Jim, because who ultimately issues this credential and sort of what network is this happening at is absolutely a question. And I think, we've looked at what are good sort of microcosms to bridge to take this first step in, because it's a big change, right? And working with those EMRs, electronic medical record systems, to interact with the credential, like pull up the chart, do those things, right? It's sort of like, what's the first step? And the first step is maybe a microcosm of a small network. And so we talked about, for example, there's a federally qualified health center. They have primary care sites, and then they have like a big hub where they do all their specialty care. Well, the primary care site knows you. You walk into the specialty care building and nobody knows who you are and nobody knows your name, and they have to pull up your right chart. So yes, everything you described, and this is just sort of like bringing that down to a microcosm of it.
Right. Now, in that example, would those FQHCs all be on the same EHR?
Yes, as a first step, but then you can start to say, well, if we're all in an HIE, maybe we trust the HIE. The HIE should be the creator of the credential, right? And it's sort of like building that ecosystem where you can start with a really small microcosm and then expand that ecosystem to say our community will trust the credentials from any one of these agencies, or it's going to be created more centrally, which is what you've described.
Right.
Yeah.
And for Cardea, in terms of a microcosm first use case, where I'm quite frankly interested for integration is like the AB 352 use case in California, where you want to apply consent rules and governance around specific elements of data that fall under the reproductive health guidelines of the law, and say, I want a broker moving my data around in California under the data exchange framework. Oh, by the way, these are the rules governing, or these are what I have put in permission for consent for sharing specific reproductive health data that I have in my record.
Yep. And of course, that would be the prerequisite to having let's call it like a security credential, a disclosure and security layer credential. Consent would be an identity credential.
Right.
Who are we talking about? Yes.
So, I think, we could talk about, somewhere we need to talk about the governance aspect of it. So as you talk about who issues and who is recognized as a trusted source of the identity credential, I think that we need to have a little bit of that discussion. I don't think it has to be super deep, but it has to be addressed somewhere. I think also we talk about like when you take the patient back to give them the services, that we talk about, we use their credential to see if that's the right patient. We should suggest some things like we look at the picture and look at the patient to see if they match. We ask them their name and see if that matches, or what are the kind of recommended or minimal practices that healthcare providers can use to say, oh, we're going to use the photo, or the photo is all we need, and that's what we're going to match on, or the photo and the name, and why are you here? Maybe that may be. So some criteria for what is that matching consist of. It's not a full scale interrogation. It's a what are the steps that we recommend? Or what do the practices want to know, use to do that? To what are they looking for?
Okay. Anything else that we want to address in the existing thing? I think that fits into the existing stuff. So anything else that we want to
Mhm.
define in the existing flows? I added the we said custodial wallet, but also the no wallet, right? I can't do technology. How are we supporting those populations? And then I put this placeholder for other advanced workflows.
So some of the advanced, Jim, did you want to list some of the advanced topics that should be addressed at some point?
Yeah, I would just put in California AB 352. That's a good microcosm starting point. And it's one where everybody really gives a damn about consent. It's kind of funny. I haven't been involved there. Keela and I have been in some of the same meetings in terms of talking about consent for behavioral health and CFR Part 2 data and blah, blah, blah. But the one thing that has fallen out of the Dobbs decision is everybody really having a life or death kind of perspective on how their reproductive health data is shared. And California has one of the first kind of strenuous pieces of legislation on limitations for it.
Excellent. Okay, and then there were a couple of others though. So that's sort of the consent. There's the linkage to clinical data. And
Yeah.
I have hinted in some of these about the referral creds and appointment credentials. And how that might help with things too.
Is there a unique facet of Cardea that would assist with those from like a management or governance standpoint? I'm just looking at them as features in the context of what Cardea can do too.
Yeah, I got what you're saying. You're saying
Yeah.
it's the same. It's not actually
Well, no, actually, no.
different.
I'm not saying that it's not good. I'm just saying that there could be things about Cardea that I don't understand why it would be particularly appropriate for those particular features.
Yeah. Okay.
I
Anything
think you
else?
leave them in there, and we can discuss that later.
Yeah. Yeah, and to be transparent, I look at everything about Cardea through the lens of the CETA pilot and how it can be expanded from there. So there's others capabilities or functionality now in Cardea besides that governance model that you used for CETA, then I'd be worth taking a look at. So
Okay. Oh, the other one would be eligibility.
yeah,
Worth
yeah,
talking about.
that's probably a solid one too.
Okay. Anything else we should, so we've got a little bit of, I'll do a little cleanup on here. And one question I have is this is this doesn't include like the where is the credential now, right? Like there's a credential passed here. We didn't quite put that on the diagram. Would it make sense to have a layer? There's like the workflow and then there's where is the credential exchange specifically. We could probably highlight that a little more clearly as like a layer on these workflows. Would that be helpful?
You might want to just, have a little icon of a credential being passed back and forth, and you can plunk it in wherever it makes sense in the diagrams without having to have a separate layer.
Yeah, yeah, okay, that's sort of what I was thinking. So that sounds good. We can add that in also, just to show where that specific kind of handshake is happening or exchange. Okay, great. Anything else to add for today? Otherwise, what we'll look to do next time is to hopefully we have 2 more we didn't get to, so we'll finish those 2. We'll see if there's any more polishing we want to do, and then we'll start to make a plan to get this into an updated white paper, which was the goal.
I'm very pleased with their progress today, and I think we're getting close on, I think another session to review the last 2 slides, and we'll be in pretty good shape.
Agreed. Agreed. Okay, excellent. Well then, without further ado, we will sign off and let everybody get to their hopefully celebrating a long weekend this weekend.
Groovy. Good to see everybody again.
Nice to see you too. And hi, Christy. Thanks for joining us.
There we go.
Bye, all.
Bye, y'all.
Thanks. Bye.
Thanks. Bye.